Okay, this segment is going to be on your ventricular dysrhythmias and covering your premature ventricular contractions, or for short PVCs, um, couplets, bigeminy, trigeminy, quadgeminy, multifocal or unifocal, meaning that they can all be facing, the PVCs can be facing the same way or in opposite directions, meaning multifocal. Unifocal means they're just coming from the same focus in the heart, so they're all going to look the same, whereas multifocal, they'll be, facing different directions and look different, and we'll see that on the strips. Um, and then towards the end, we'll cover the more dangerous of our arrhythmias: ventricular tachycardia, ventricular fibrillation, and ventricular asystole, or asystole. Basically, sometimes you can have ventricular asystole where you can just see, all you'll see is P waves, which is basically not having a pulse. And sometimes you'll just have uh, no function at all, even in the atria. So ventricular asystole is where the ventricles are not contracting. You'll see no QRSs, but you'll see P waves. But if you have just asystole, you will have no mechanical uh, stimulation at all, and you won't see any waves. But let's start out simple. We have our PVCs, and these are two strips here. Let me just move this around here. And what we see here is we see the typical classic description of a PVC, where you have this, you're looking at a rhythm, whether it be sinus or sinus tach, or normal sinus rhythm or sinus tach. And a lot of students will ask me, do you count these as beats? And the given rule is, if you're not sure, put your hands there on a pulse, a radial pulse, a brachial pulse, whatever. And if you feel a beat, and if you do feel a beat, that means they're perfusing, and you should count them. So for testing purposes, we're going to count them. We're going to just say they perfuse. So we're going to give this rate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. So we're looking at a sinus tachycardia. And what we see is these wide, bizarre beats that are just, if we went through our 5 steps, we would definitely say that not all the QRSs look the same, right? And what this is just a premature ventricular contraction. It's like before we saw the premature atrial contraction. So it's a ventricular contraction that in and itself comes early, okay? And so these both look the same, okay? And so we would call those, this is a sinus tach with two, PVCs that are unifocal, okay? Because they look the same, they're facing the same way. The underlying rhythm's a sinus tach, and we have two unifocal PVCs. Whereas down here we have, a sinus rhythm. Okay, well, let's see. Let's say these perfuse, like we're going to do 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. A sinus rhythm with what we see, these wide, bizarre, early ventricular contractions, and they are actually, facing in different directions. So this would be a sinus rhythm, right, with two multifocal PVCs. Okay. Now on the next slide, you'll see where we have different combinations. And in general, the rule says if you have more than 3 PVCs in a row, that's a run. That's basically VTAC, run VTAC. So that's why they call this ventricular tachycardia, even though it's a bunch of basically that's what VTAC is. It's a bunch of PVCs in a row. So if you go over here, let's look at the same thing, multivocal PVCs. One is facing that, where it's wide, bizarre, but facing the opposite of this one. And so we would call that 1, 2, 3, 4, 5, 6. That would be a sinus rhythm with two multifocal PVCs. Whereas here, I would call that 1, 2, 3, 4, 5, 6, 7, 8. If these perfuse, which we're going to say that's a rate of 80, and you have a you know couplets and a 4-beat run of VTAC, okay? And here is a little different because you see where every other beat is a PVC. So there's a regular beat, PVC, regular beat, PVC, regular beat, PVC. And we call this bigeminy. Okay. Now, this one is every third beat, you have a PVC, and that is called trigeminy. Now, you may have quadrigeminy where you have every fourth beat, but in general, treatment of PVCs, why do they happen? Typically, some people are more apt to PVCs where you have, when they intake stimulants like caffeine or depressants like alcohol, nicotine, aminophylline, which is a respiratory drug, epinephrine, isoproterenol, DIG, especially electrolyte imbalances, especially when you look at mag or potassium that are low, you are more apt to have PVCs. Hypoxia, fever, any of these states can cause these PVCs. Now, clinically, to be significant, we look for, an increasing occurrence of PVCs is usually not a very good sign. But if you're a good nurse, you're going to figure this out way beforehand and you're going to start seeing more PVCs. And you're going to check things like oxygenation. Do they take their oxygen off? Do they have a fever? Check a BMP, get the labs, check and see if their potassium's off. Are they, decompensating in any way? Hopefully, you will walk into the room and actually assess your patient. Sometimes in heart disease, especially somebody with a very, very weak heart, low ejection fraction, a PVC may actually cause a decrease in cardiac output and may, precipitate some heart failure or angina, just depending what their starting point is. But in a normal heart, they're usually benign. But, we need to monitor what that particular patient's response is. So we have, you know, what usually the PVC is not going to make a peripheral pulse, that you can palpate, but if they do, we do count it, and for testing purposes, we will count them. An apical radial pulse rate should be assessed exactly to determine if there's a pulse deficit. So how do we treat? Well, more clinical significance. This represents ventricular irritability, and we see them often with when people have reperfusion therapy. When they, if we have a clot from an MI and the reperfusion starts, we often see, a lot of PVCs, and sometimes they will lead to VTAC. So, after coronary artery clot, thrombolytic therapy, or in an acute MI, the most common arrhythmia is going to be, a VTAC, or you'll start to see PVCs that will lead to VTAC. So be very, very careful when you have somebody that's had an intervention like that. So, sometimes we'll see it after, they go in and do a balloon angioplasty, or they do, open up where the plaque is, or or they reduce the plaque with a percutaneous coronary artery intervention. So, be very aware. You'll see maybe some more PVCs, and be very careful. Start seeing what you can fix to decrease this ventricular irritability. Sometimes you can't do anything, but what if they pulled their oxygen off? Make sure that you're checking these things. What if their potassium is 2.0? What if they're running a fever? These are things that you can fix to make sure that they don't go into VTAC. And here's more whys. We talked about the hypokalemia, the hypomagnesia. Some of those other things are. I think I listed them twice. Okay, but you'll see it with especially in older adults. You will see and in postmenopausal women. Caffeine will cause PVCs. Okay, so what's the treatment? The decision to treat a PVC is in the emergency room or outpatient setting depends on the clinical scenario, period. Okay, in the absence of cardiac disease, isolated asymptomatic ventricular ectopy, meaning recurrent PVCs, regardless of the configuration or frequency, does not require treatment. Okay, so they're usually benign. With cardiac disease, certain toxic effects like electrolyte imbalances will cause PVCs more likely to pop up. So we want to make sure that they're on telemetry. You put some oxygen on them, you get a 12 lead, and note the following: make sure that they aren't hypoxic. Treat that. make sure they, it's not a drug toxicity. So if you got a toxic drug like Dig on board that's, may cause this, then you can do, your Digifab or a tricyclic. You can give bicarbonate. If it's an overdose of aminophylline, you can possibly do hemodialysis. Fix your electrolytes. Particularly your mag, your calcium, and your potassium. Okay. So your treatment is based on the cause. You want to make sure you give them, oxygen therapy because that's the number one cause usually, and electrolyte replacement. And if the PVCs are something that are recurrent, sometimes you'll see them start them on some beta blockers or procainamide, amiodarone, or lidocaine. Very rare though. If there's no underlying heart disease, PVCs are not usually treated, like I said, and you manage the contributing cause. You replace the potassium, you replace the mag, you replace the calcium, um, if that's the cause. And if you're looking at more than 5,000 PVCs in a 24 hours, is what you'll be able to monitor. That is what they had in the book. They usually put them on a beta blocker, but anything under that, you're not going to see, much treatment unless they become very symptomatic. Okay, so here we get into ventricular tachycardia, and I'll show you stripped down a little bit. But typically, a run of 3 or more PVCs is considered ventricular tachycardia, but we do not treat that because it may just be based on what we just talked about with PVC. So, correcting these things like hypoxia, electrolytes, these may be something that we can, keep it where it won't become sustained. So once it becomes sustained, then we got a problem, right? So, you may have monomorphic, meaning that your VTAC is all look the same, or polymorphic, sustained or non-sustained. And I know this gets confusing, but pretty much, your treatment for ventricular tachycardia, I want you to know that if it's symptomatic or non-symptomatic. So that means that if it's symptomatic, then you're going to automatically, you think symptomatic, you think that they are, their loss of consciousness, they are, you're not going to be able to palpate a pulse, then you have to start CPR, right? And then, of course, the only thing that's going to fix that is defibrillation. If you have somebody that's a stable VTAC and they're sustained in VTAC, they may be sitting up and talking to you. And of course, you're trying to figure out what to treat here. But in the meantime, if they're sustained VTAC, you try to, give them some time. And if they do not respond to the things that you have, kind of figured out were wrong, then you're absolutely looking at synchronized cardioversion. So it's a little different there. VTAC unstable, you're going to give defibrillation, and VTAC that's stable, that's sustained, both sustained, then you will definitely do some cardioversion. But if you have a non-sustained VTAC, then we're looking at maybe starting them on some drugs. But if you're not, if you have runs of VTAC and you're unstable, then we got to do something more, right? We've got to absolutely try and get you on a rhythm correcting agent, but we also might look at something like synchronized cardioversion. So those are the big things to know about VTAC. So know the causes. These are the same thing. Your heart disease and MI may be causing, maybe from a reperfusion. You've had some type of intervention where you're starting to reperfuse the heart from a angioplasty, or, and so you're starting to have these. And we also look at what we call, we look at, electrolytes. It's a hypo or hypomagnesemia or hypokalemia, valvular heart disease, heart failure, drug toxicity, sometimes steroids. Hypotension may cause cocaine, illicit inhalants, But we also look, once we go through all this, we look at the 5 H's, and I mean, not the 5 H's, but the H's and the T's. Is it hypovolemia? Is it hypoxia? Is it acidosis? Is it hyper or hypokalemia? Is it hypoglycemia? Is it hypothermia? Then we look at the T's like toxins, tamponade, tension pneumothorax, thrombosis, and trauma. In patients that go into cardiac arrest, from VTAC where there's pulseless, you know, when you're going into VFib, VTAC is usually the rhythm you see right before they deteriorate to VFib. Okay. So when you got to be aware that when you're dealing with somebody who is absolutely in a code situation, they're in VTAC, that the possibility going into VFib is very high. And once they go into ventricular fibrillation, it's very difficult to get them out. So you're looking, make sure that you know that these people are at risk right here. Anybody that's got MI, a CAD, or electrolyte imbalances, cardiomyopathy, mitral valve prolapse, long QT syndrome, DIG toxicity, central nervous disorder, and just be able to look through these and know that that this is what it could deteriorate. And VTAC in itself is a deterioration. Don't get me wrong, because it requires defibrillation if you're unstable. But then the other thing that we give them, of course, is we have to give them a rhythm drug, and a lot of times we give them, we give them amiodarone, and of course we're following our CPR guidelines. With this unstable person, we're making sure that we're doing our chest compressions, that we're calling the code, that we're getting the crash cart in there, we're calling for a defibrillator without a pulse, and then and we will give them either, well, I got epinephrine, but so sometimes we will do your amiodarone or beta pace or for VTAC. Okay, so here's VTAC. This is unifocal VTAC. Okay, see how every and this is probably, this is not a perfusing rhythm, probably not. So when I say non-perfusing, probably without a pulse, but there are times when some people will have a pulse, very rare. But those people that are stable VTAC, they will get synchronized cardioversion versus defibrillation. Okay, so that's a monomorphic VTAC that we just looked at, and over here is the different treatments. Now, for a monomorphic VTAC, you want to do oxygen, amiodarone infusion, if they're stable, and of course, if they don't respond, then you got to do some synchronized cardioversion. But an unstable monomorphic VTAC, you need to right away DC cardioversion. And before, that's happening, you need to be doing CPR. You need to be doing chest compressions. You need to be starting that whole chain of survival. Okay. Now you may have, which is monomorphic pulseless VTAC, which is unstable VTAC. Like I said, oxygen, CPR till the defibrillator gets there. And of course, you'll give your amiodarone. And the dose of amiodarone is 300 milligrams IV, then 150 milligrams IV. Okay. Now, that was monomorphic VTAC, but look at polymorphic VTAC. Now, polymorphic VTAC used to be called torsades de pointes, and many people will still call it torsades. So if you see it, the reason why it's called torsades, it's called twisting of the points. Okay. So it's kind of like a tornado, it's like, it's twisting of the points is the translation of torsades de pointes. But the new name out there now is polymorphic VTAC. So there's this long thing that I wrote up for you guys for whether you're gonna automatically give amiodarone or if you're not. But if you'll read through that, I mean, I'm not going to you know be much on if polymorphic VTAC is stable and the patient has a normal QT interval, that means that you're seeing some sinus beats somewhere. So it may be where they're in VTAC and then you'll see some sinus beats and you'll be able to look at the QT interval. So that is kind of like, you're probably going to have a pulse with that because you're going to have sinus and they'll go into VTAC, that polymorphic kind of torsades. Then it's treated in the same as monomorphic or just like it was a monomorphic VTAC, and give them some amiodarone if the patient does not respond to synchronized cardioversion. But if this patient has runs of polymorphic VTAC, With a sinus rhythm, you can see the QT interval, right? So if it's prolonged, then you're gonna the first thing you're gonna look at is giving a mag, mag sulfate, because people with hypomagnesium tend to go into torsades or polymorphic VTAC. And so magnesium is unlikely to help somebody with a normal QT interval, but somebody who has a QT interval that is prolonged, it's most likely a mag related thing. Okay. So it's, a lot of times you'll see them just give mag because it's not going to hurt them. It's just not going to do anything. Right. Okay. So, but if it is a QT interval problem where, that's why they went into VTAC, or a hypomagnesium problem that caused this prolonged QT interval and has led to this polymorphic VTAC, the MAG is going to fix them. Okay. So very, very important, because we give a lot of diuretics, and when we give diuretics, we cause hypokalemia, we cause hypomagnesemia from diuretics, and so we need to correct that abnormality. We give a lot of DIG. We may see this with DIG, and we can treat it with antidigitalis or Digibind. But we if you have an unstable, these are stable up here. Unstable VTAC, polymorphic or monomorphic, you got to defibrillate them. Okay. Anytime you go unstable, you got to move to defibrillation. So if you're in that room, you get called, you got to go to the room, you grab the crash cart. In the meantime, somebody needs to be doing CPR. Of course, you're not going to be doing CPR on a stable patient. They're going to be coming out of the bed ready to kill you. But with somebody who's unstable, that usually unconscious without a pulse, you're absolutely going to start CPR first while somebody gets to crash cart. Hook them up to the crash cart. Doc gets in the room. He'll look at the rhythm and he'll make that decision. Okay. So your unstable polymorphic VTAC. Once they're unstable, CPR on code, right? So you don't really have to think beyond that. But if you want to know why the doctor does certain things versus the other, that may be it. But you may see him give mag and it won't work. That's why. But you won't see mag, you won't see him give mag with a not a multi, but a unifocal VTAC. They're just going to try to defibrillate them if they're unstable. With the monomorphic VTAC, you're going to see a lot of amiodarone. So you got, with CPR, follow CPR guidelines where you're doing 2 minutes of CPR, before, you got to do 2 minutes straight of CPR. And like I said, the treatment that we do with torsades is mag sulfate. And then, of course, if that doesn't work, we're starting the amiodarone, because it's got to be the other where you have a normal QT interval. Okay. This, my friends, is VFib. And this is coarse VFib. It's very, very easy to see. Sometimes you'll have fine VFib where it's very, very fine, and it'll look like they're off the monitor sometimes. So if they're yelling your patients off the monitor, don't just walk, run. Okay. If you see any of these rhythms, VTAC, polymorphic VTAC, frequent PVCs, that kind of stuff, you need to be walking into that room now. If you see this, you better run. Okay. So it's either going to be this really kind of choppy VFib, or it'll be very fine. Now, I've had patients pull themselves off the monitor and it looked like that. I ran to the room, I'm all out of breath, but thank God they're okay. This is a pulseless rhythm. It's never, if they're in true VFib, there is nothing going on but ventricular fibrillation. So that makes sense that they would have no pulse. So my thing is CPR. Boom. We got to do CPR. We got to call the code. We got to get the crash cart in there, because the only thing that will fix VFib is defibrillation, not synchronized cardioversion, defibrillation. That means that we're going to put them and we're going to give them a little bit of Alabama power, and we are going to try to shock this rhythm out. Now, typically, why does this occur? We look at the same thing with VTAC. We look at, acute MI, CAD, cardiomyopathy. We look at the H's and the T's. While we're coding, we're thinking these things. Is this patient hypoxia? So we're getting ABG. Is this acidosis, right? Is it an electrolyte problem, either hyper or hypokalemia, hypoglycemia, hypothermia? We look at T's. We look at toxins, tamponade, tension pneumothorax, thrombosis, like in a coronary artery, which would be an MI, or pulmonary thrombosis, which would be a pulmonary embolism, or trauma, and typically VFib may occur during cardiac pacing or cardiac catheterization because they're irritating the heart. We may see VFib occur with coronary perfusion after fibrinolytic therapy or thrombolytic therapy, like we talked about before. When we see accidental electrical shock, hyperkalemia, oops, wrote that twice, acidosis, drug toxicity. What is the treatment? You have to defibrillate them. That's the priority there. If the defibrillator is not readily available, you need to be doing high quality CPR, and giving that. And the only drug that we use for VFib is epinephrine. Okay, and first, and then the doctor may ask for some amiodarone. But those are the only two drugs that you may see. But for your purposes, epinephrine first. CPR, then epinephrine is the drug. I'm sorry, CPR while you wait for the defibrillator, defibrillate them. Then you're going to give some epinephrine, and this is all. This is like the third choice, and we give it the same way: the 300 and the 150. Okay, so this is asystole or ventricular standstill. It's sometimes will look like fine VFib. This might be fine VFib. You don't know. You got to go in there and make sure they're not off the monitor, because this could be somebody off the monitor. You hope. If this is it, this is the chance of survival here is very, very low. You got to act fast. So what do? We're going to look at the same stuff. We're going to look at the H's and the T's, and the treatment is CPR. Okay. Here is the deal. All you Grey's Anatomy watchers, you cannot shock this. Okay. This will not correct with defibrillation. That's why we need to. If somebody goes into VFib, we want to keep them out of asystole, because once we go into asystole, the chances of us getting them out of asystole is very low. So when we have this, the only thing we really can do is try to give them some epinephrine. But of course, we are going to give immediate CPR because we have no cardiac output, just like with VFib and unstable VTach. You have to get that CPR started. Same thing. Call the code. Get the code cart in there. But shocking this patient isn't going to help. You need to give them epinephrine. Now, that's to say you're still going to put them on, from the crash cart. If they're not, you'll put them onto the monitor from the crash cart, right? Hopefully they're on telly, and that's why you picked this up. Put them on the monitor from the crash cart, and you will start CPR until everybody gets there. And once you'll look at the rhythm, you'll check for pulse, no pulse, asystole, right? Then the doc is going to ask for some epinephrine. And what we usually do is we just keep pushing some epinephrine, right? And then they might decide last ditch thing, hey, we might be looking at VFib. Who knows? Let's try to shock them. And that's the only reason you will see a doctor shock asystole, because it's not going to work if it's true asystole. But if you're looking at that, and it, on the monitor, and you're like, okay, well, this may be fine VFib. I don't know. Looks like asystole. We're going to give him some, and then the last ditch thing is you might see him shock him, because we got to do something, right? So let's just stop here because we're going to talk about junctional rhythms on the next recording. Okay. All right. Talk to you later. Bye.